Kalantar for giving us the opportunity to present. My name is Kalantar, nephrologist from Southern California, addressing the unmet need for renal protection, SGLT2 inhibitors. So now this slide is here to share with colleagues, no matter what your specialty is, nephrologists, cardiologists, that we in the kidney world, we have a World Kidney Day every year and a theme, living well with kidney disease. And with that, I meant to say that since I'm also the co-chair of the World Kidney Day, every year there is a theme. The theme of the 2021 is living well with kidney disease, which is very relevant to what we're discussing. That means you have CKD, what to do to feel that you are in control and you not have anxiety or under anxiety about this. If you have other suggestions or ideas, please let me know what the theme or themes of 2022 or other years should be. So how does SGLT2 inhibitions modulate glomerular filtration? How does it work? Here, next slide. Now, this is a simplified version of the glomerulus. And you can look at this as a filter machine where blood enters the glum and blood leaves the glum, but part of this is filtered, is oozed, is leaked. This is called filtration, right? Or leaked part of the serum, which becomes urine after 90 to 99% of this is reabsorbed. So therefore, we call this glomerular filtration, and we have a rate for that. And based on what also Dr. V showed here and the heat map and others, a simplified approach, the heat map in 1999, when CKD for the first time was defined by the National Kidney Foundation as a damage to the kidney that lasts more than 3 months, or if kidney function is reduced below 60 ml per minute per certain unit of the surface area, especially if it's below 60, is already stage 3. Not infrequently, your patients come to me or ask you, doctor, I don't even have, I have not only CKD, I have stage 3. It's not even stage 1 and 2. What should I do? There are sometimes emotional interactions. And this comes from this 1999 National Kidney Foundation in the United States. So why is it important? Because in the United States, there are over 500,000 people on dialysis. Currently, it's 558,000 people receiving dialysis therapy. It's very expensive. It's around $80,000 to $100,000 per year, more than average salary of a nurse or much higher than residents and fellows, and over 700,000 with ESRD, including 200, 150, 200,000 of them with kidney transplant. It all goes back to here, why kidney disease happens. And I'm going to share with you the concept that I share with you, that means glomerular filtration rate, and glomerular filtration going up or down. But before it goes down, before we lose glomerular filtration rate, it goes up. Now, that's fascinating concept. It's called hyperfiltration, right? And we have 1 million, 500,000 to 1 million glomeruli based on what age we are and how healthy our kidneys are. Once there are more loss of these nephrons, the others need to compensate for the loss of nephrons, right? So the other are going to work harder. And therefore, as you can see here, right now, glomerular filtration rate, if it's 90 to 120, every day, and if you have 3 to 4 or 5 liters of blood, just roughly 5 liters. So every day, 50 to 60 times your blood is being filtered through the kidneys and reabsorbed. 99.9% of it is reabsorbed. Now, if you look at here, the health of the kidney is dependent on intraglomerular pressure, the pressure inside this tiny little glomerular, the vascular tufts. And it was discovered or hypothesized, we're not even sure, we still call it hypothesis or theory, the theory of intraglomerular pressure, that once the pressure is high inside glomeruli, there is going to be, in short term, you gain more GFR. In long term, there's going to be damage to the kidneys. And why this happens, this is also what we see in real life. That means among your diabetic patients, sometimes you see creatinine is 0.6, 0.5. You say, wow, this is actually excellent kidney function, but this is the beginning of the hyperfiltration. And then that's usually is associated with microalbuminuria that you see, and kidney function then it starts going downwards. So now if you look at again the hypothesis, the hyperfiltration hypothesis, that means essentially there's compensatory hyperfiltration followed by increase interglomerular pressure, leading to more damage to the remaining nephrons, and that leads to the vicious cycle. And we are here to find a way to break this vicious cycle, and that's how I'm going to present to you the pathophysiology and the ways of the kidney disease, chronic kidney disease, and the ways to modulate it and to maybe to slow the progression. So now, that comes the question. Can CKD be cured or reversed? And I say no. When my patients come and fly to see me and say, doctor, can you reverse it? I said, no. They said, can you at least stop progression forever? So I say with creatinine of 1.3 or cystatin of 1.1, and I say no. And then they ask, is there anything else to do? And I say, yes, we can team up together to slow progression. This is one thing we can do. And if we can slow progression so that your kidney function lasts longer before it goes to 10%, that compared to your age, then we have won, right? Then we are the winners. So this is what we do. Therefore, essentially, this is the concept. And I'm using ACE inhibitors and ARB because this is something everybody's familiar with. We say, why do we start patient on ACE or ARB? Initially, there is a drop in kidney function, and that's the target of hyperfiltration that we discussed. After that, on long term, you win. All right, so I'm going to expand on this and now talk about how this modulation of interglomerular pressure is possible. Well, here you have one entry and one exit to the glomerulus. And one way is to open up the efferent arteriole. That's what ACE inhibitors and ARBs do. The other way is to go after the afferent arteriole, right? That's even more effective. You go right after the entry to the problem. And how can you do this? Well, I tell you what, this is essentially what we want to do. So you have a kidney that is overfunctioning, GFR has gone above 120, and these are different causes of hyperfiltration. That means overcompensation means a car that is being overused and abused, obesity, diabetes, high erythropoietin intake, solitary kidneys, pregnancy, polycystic kidney disease, focal segmental GN, pretty much all of them. But look at here, number 1 and 2, obesity and diabetes, right? So now, once again, we are here to see how we can help lowering the pressure inside glomeruli. And as we discussed here, one way is through ACE inhibitor and ARB, and the other one is to go to afferent arteriole, and that could be done. But what I do, not infrequently, I ask patients to eat less protein, to lose weight if they're obese, or by means of the medications we're discussing today. And this is the figure that a few years ago, they invited me to New England Journal of Medicine to write a review about this, and I highlighted here the afferent arteriole, our target. At that time, SGLT2 inhibitor concept was just emerging. So now, let me touch base on diabetes that Dr. V also mentioned. Diabetes is sadly, I have to say sadly, the contributor to half of our patients in nephrology, right? To the point that this is now overwhelming. That means, as you can see here, traditionally 20 years ago, I would have given this talk that hypertension, glomerulonephritis, other polycystic kidney disease are important causes, and diabetes is an emerging one. But now it's more than half. And sadly, both type 1 and type 2, at least a third of them, if they live long enough, sadly, they will have chronic kidney disease. It's also called sometimes diabetic kidney disease or DKD. Now we're going back and forth. We said to call it CKD diabetes or diabetic kidney disease or diabetic nephropathy. So you're more than welcome to use any of them. But the impact is overwhelming, as you can see here. This is yet another piece of data out of many suggesting that diabetes substantially contributes to CKD burden in the United States. Right now, out of over 500,000 people on dialysis, extensive dialysis, half of them are there in the dialysis clinic because of diabetes. So prevalence of CKD diabetes used to be 25%, but it is 50%, and now and it's increasing. Now there are more bad news. If the kidney disease is because of diabetes, progression of kidney disease is also faster. So as you can see here, comparing, this is one of the studies using the Kaiser Permanente data of Northern California. They divided patients into fast progressors and slow progressors. And as you can see here, there are much more fast progressors in diabetic kidney disease or DKDs compared to non-DKDs. That means CKD due to non-diabetes. And this is also relatively well known. And this is also an area of unmet need. Of course, we have done a lot in this area for the past 20, 30 years. And this is another one to suggest that CKD patients have 6-fold higher risk of cardiovascular death. So now I share with you 3 components. Number 1, diabetes is overwhelmingly a major cause or a number 1 cause of kidney disease. Number 2, diabetic kidney disease is faster progressor. And number 3, patients with DKD, diabetic kidney disease, also have worse outcome. That means in terms of their survival and in terms especially due to cardiovascular disease. All right. So CKD patients have 13-fold. I mean, this is not 13% higher, it's 1,300% higher. Wow, this is gigantic, right? All right, so now I would like just to end this part of my talk about diabetes and going back to the concept of hyperfiltration. Why? Because hyperfiltration, I showed you this slide initially that first creatinine becomes lower before it starts going higher, right? Or cystatin C as we measure nowadays. And this is a very nice, the mother of all translational studies 30 years ago by Dr. DeFronzo and Dr. Kathy Tuttle, who is a nephrologist. They showed when they infuse amino acids to diabetic patients, their hyperfiltration was even higher than non-diabetic patients. That means you infuse amino acids, that's actually the impact of high meat, high protein intake. There's almost always hyperfiltration. There's no question. This is evolutionary important for us. You eat meat, you need higher GFR. But just look at here, for a diabetic kidney disease patient, is much higher, right? That means your GFR goes from 90s all the way to 160 within 2 to 3 hours after you eat a high load of protein. All right, so now, how does this now translate into SGLT2 inhibitor? Well, this slide tells you everything, almost everything about what SGLT2 inhibitor was or is. So the whole point here, the keyword here is what I defined here, SGLT, sodium glucose transfer protein. This is something that we nephrologists and kidney physiologists have been familiar with for years from the beginning of our training. And the bulk of SGLT is actually the proximal tubule. And we need that. Why? Because 90% of sodium and especially glucose is absorbed. And then the rest of 10% is absorbed in the distal part of the nephron. Kidneys are there not to leak glucose. Now, is it good to leak glucose or not? Always we thought it's a bad idea. But the whole point of SGLT2 inhibitors is to inhibit 90% of SGLT so that we don't reabsorb glucose. And you may say, wow, what a fascinating, interesting mechanism to get rid of extra burden of glucose, right? So this is essentially what happens. And not only that's the simplified version of SGLT2 inhibitor, because also the sodium that goes to the distal nephron will modulate further the tubuloglomerular feedback apparatus and leads to more beneficial or salutary effects. So I'm going to go here and just first of all share with you what the consensus is across several credible entities. For example, quoting ADA, SGLT2 inhibitors should be considered in patients with diabetic nephropathy with EGFR above 30, that means CKD stage 3, 4, and 5. I'm sorry, CKD stage 3, 2, and 1. And heart failure and other things. Look at here, American Heart is also consistent. Consider SGLT2 inhibitor for patients with diabetes and CKD. at the risk of cardiovascular disease. Pretty much everybody with CKD is at risk of cardiovascular disease. And KDIGO, which is an entity, a guideline entity, says the same thing. So how do these data come from? We go all the way back in 2013 and 14, where SGLT2 inhibitors, the first data suggests that this is an interesting diabetic medications that leaks out the entire glucose burden. But then the studies, including EMPERIC, Canvas, and DECLARE, published almost every year. And these were studies by cardiologists focusing cardiology or MACE outcomes, also had secondary and analytic outcomes suggesting that not only does SGLT2 inhibitors, and no matter what it is empagliflozin, canagliflozin, or dapagliflozin, all three of them, they are relatively consistent in terms of improving cardiovascular outcome. That means the three MACE outcome, or major adverse cardiovascular events, MI, stroke, and death, cardiovascular death, but also decreasing or improving macroalbuminuria and microalbuminuria, which we now call level 1 and level 2 and level 3 albuminuria, and improving renal outcomes. And a number of secondary analyses of these papers were published. And these papers led, and this new discovery led to having additional studies just be designed for renal outcomes, right? Because the cardiovascular outcome was overwhelmingly positive. And this is the history that I said, 2014 with the DAPA and other papers. And then we had DECLARE and DAPA heart failure, and your cardiology colleagues can brag a lot about them. That's another half an hour to an hour of discussions, and DAPA-CKD. So let's now move on with more focus about kidney function. So some of these data, they also included, as I said, the cardiovascular diabetic clinical trials, and these are the mother of all randomized controlled clinical trials, each with 5,000 to 20,000 patients. So DECLARE, and some of them have more CKD subgroups than the others, assuming that the definition of CKD is somebody whose eGFR or estimated GFR is less than 60. And as you can see, for example, DECLARE compared to DAPA heart failure, compared to DAPA-CKD, and I'm going to move on to the next slide to compare the proportion of CKD in some of them. If we define CKD according to GFR below 60, as you can see, for example, EMPERIC had roughly 25 to 30% CKD patients, and Canvas and DECLARE had a little bit less CKD patients. Now, why is that? That one study has more, one study has, it's all based on which countries, which centers they go, because these studies, they did not focus on CKD, they focus again on diabetes and diabetic patients with heart disease and others. And then if you define CKD based on albuminuria above 300 milligrams per gram of creatinine, then you can see that you have another 5 to 10%. Now, what are these two? These are the two studies that were then designed to focus on CKD, right? And I'm going to spend the final 10 minutes of my talk on CREDENCE and DAPA-CKD. As you can see, these two studies have much more CKD patients per definition of below 60 GFR and per definition of albuminuria. So now let's delve into these studies. So studies in CKD. Now, there are three, actually, in reality, right now, there are two studies, CREDENCE and DAPA-CKD. Why I say 2 out of 3? Because EMPA-CKD is ongoing, but let's see what CREDENCE and DAPA-CKD showed. And here, maybe just, I apologize for fine prints here. There are over 4,000 patients in each of them. And I'm going to go over some of the inclusion criteria. So usually the inclusion criteria on almost all these studies are eGFR above 25 or 30. As you can see, for CREDENCE is above 30, for DAPA-CKD is about 25. And the name for you to remember, D is dapagliflozin and C is, I'm talking about DAPA, EMPA, and canagliflozin. So, and empagliflozin study is still ongoing. So CREDENCE, canagliflozin and renal outcomes in type 2 diabetes. So this study it targets only patients with CKD in diabetes, or also known as DKD. Double-blind placebo-controlled trial, eGFR 30 to 90, urinary albumin to creatinine ratio above 0.3 grams per gram, up to half a gram. So they don't want to go to extreme cases of albuminuria. A1C, as you can see, everybody has to be on ACE and ARB. And composite renal outcome, that starting dialysis or transplant or eGFR below 50, which is called CKD stage 5, or doubling creatinine, or death from renal outcome or cardiovascular outcome. All right, now, bang, the study suddenly had to be stopped. Was it good news or bad news? Well, actually good news. So look at here, CREDENCE study, stop trial, stop early after planned interim analysis. DSM board advised, and yes, all 4,000 patients actually were, as you can see, from 34 countries here, but the follow-up that was supposed to last 1+ year younger was not necessary. And why is that? Let's look at here the outcome. And this is from Vlado Perkovic, who is a nephrologist, dean of actually a nice medical school in Sydney, Australia now. And he and others have spearheaded a number of these clinical trials. And Dr. Vlado Perkovic here showed very nicely that, as you can see, the separation of the curves in terms of renal outcomes, the primary renal composite outcome, is too good to be true, right? But it's true. This is what we see. And essentially, this is the main figure, and you see here the increase the size of the figure for the sake of precision. And let me share with you more. Across all subgroups, you see the hazard ratio on the good side. That means on the side of below 1. Remember, if a hazard ratio is calculated and adjusted and do everything you can and put it in different subgroup of patients with CKD stage 3B, 3A, and others with eGFR 30 to 45, which is 3B, 45 to 60, which is 3A, 60 to 90, which is CKD 1 and 2. You see relatively consistent data are all showing that there is a benefit of using these medications. So going to the next one, again, DAPA-CKD, I talked about this double, okay, I'm sorry. Now I'm going to the next one, which is DAPA-CKD. That was CREDENCE, right? So DAPA-CKD now is very interesting in that DAPA-CKD looked at patients with and without diabetes. Wow. Because somebody says that, look, I just make up somebody, not somebody. A lot of people say, let's really do this also in non-CKD, non-diabetic patients. And this is what you see now in DAPA-CKD using Dapagliflozin. And this shows where the study was performed, different countries. Again, the state-of-the-art, classic, the randomized placebo-controlled trial, Dapagliflozin 10 milligrams versus placebo, double-blind, and bang, the study was stopped. Again, bad news or good news, this was yet another good news. Study was stopped because without requiring to sitting down and waiting for more events, there was enough events, and the event separation was remarkable, as you can see here again. And you may say, wow, this looks exactly like that one. This is DAPA and Canagliflozin, and yes, so that's essentially a class effect here. And of course, there are certain distinctions, but as you can see here again, the separation of primary renal outcome, now this time with inclusion of non-diabetic patients is the same, right? And now let's go over some of other more granular data. I would like just to share with you here, secondary composite for renal outcomes when eGFR declined more than 50%. So anyway, they looked at it different ways also. Most of these were predefined outcomes, secondary outcomes before the study was unblinded. Secondary composite endpoint of cardiovascular outcomes and CV death or CHF hospitalizations in these CKD patients. Also, you see again the same. And the only SGLT2 inhibitor trial to show reduction in all-cause mortality. So remember that we talked about cardiovascular mortality, we talked about prior studies on MACE, means major adverse cardiovascular events, which is usually three components. That means MI, stroke and cardiovascular disease, but this now you're looking at all-cause mortality, which also is remarkably reduced. Once again, similar to CREDENCE data, DAPA-CKD data also shows that all subgroup hazard ratios on the good side, that means the side below 1, relatively consistent, or almost, impressively consistent actually, across age groups, sex, gender, race, and also GFR below and above 45, that means CKD stage 1A versus 1B, which is very important for us nephrologists. And now what is this? This is the one that I want to share with you. That means, look at here. This is Dapagliflozin patients. When they start medications, they lose 3 to 4 units of GFR before they gain it. And this is the topic of hyperfiltration I talked with you, because people are saying, why it happens? Well, if something is going to work, that thing needs to go after the hyperfiltration part. That means it really needs to not allow nephrons to be overwhelmed and overworked. And this is what you see. And when you lose hyperfiltration, your creatinine on paper goes up. If it's 1.2, it goes to 1.4. But then over time, you see that the slowness of the curve is impressive. And these data are relatively consistent with across different, it's not dapagliflozin, with all of them. So people have asked me, doctor, so is good enough to give this pill? And some colleagues, they call it flozinations. I'm a flozinator, right? Like statinators among cardiologists. And I say, good for you to be flozinations or flozinator, but data on diet, interaction of diet and SGLT2 inhibitors are coming. That we don't have much data. This is, for example, one of them that showed in patients who had, these are 2 small studies. These are very small studies. I mean, these are compared to the study I share with you, this 230 patients, nothing, right? It's like nothing to gain out of. But the reason, these are the only 2 studies that looked at also how much protein patients eat or how much plant-based protein, and suggest that there is a biological plausible trend, which then make it with P interaction, suggesting that low protein diet may enhance or have additive effect on SGLT2 inhibitors. That means SGLT2 inhibitors work, but there may be even more gain if diet and lifestyle also is adjusted. But these are only trends and we can only hypothesize. One slide on adverse effects. Are there everything has a price, right? And here is one of my tweets, and you can find it many, many places. And usually 6 to 7 things are mentioned. 1 or 2 of them are real. The other ones are exaggerated. Genital mycotic infections. Imagine anything that does not allow glucose to be absorbed, but your urine becomes essentially a sugary water, and you go and pee. Even in 1 drop could, if your hygiene is not accurate, could really cause certain problems. So genital mycotic infections in the genital area is probably one of the things that are seen in some patients. Urinary tract infections. Now, there was a discussion about patients become dehydrated, hypovolemic. I have not seen that, but I usually tell my patients that, look, this is what I expect from you. This is the diet and lifestyle. Ketoacidosis, it's called diabetic ketoacidosis. Here, another paper called it euglycemic ketoacidosis, so I like it a lot. So that happens rarely, similar to metformin, right? Metformin, I always say that could cause lactic acidosis, is extremely rare. Now, one study out of everything, out of many studies, just one study in the past showed a high rate of amputations, but all other studies did not substantiate that. There was also some trend about fractures and AKI. So I would always say that, yes, number one could happen. I have to warn my patient. Number 2 could also happen. And then because of some of these concerns right now, we cannot start. We may not start. I mean, as of right now, the state-of-the-art package says that SGLT2 inhibitor should not be started if eGFR is below 25, but things may change. All right, so I'm going towards the end of my presentation. This last one, the question is, if something is really good, do we have real-world data? Yes, my colleague, Dr. Al-Ali, started actually from the VA data. He's a great colleague and nephrologist, and also associate chief of staff in a great VA hospital. He started looking at veterans data, And these are data not post-marketing. So we should be able to see what we expected in randomized trial. And yes, this is, for example, one paper published in Diabetes Care a few months ago, and in late 2020, intention to treat survival probability. Look at here, SGLT2 comparing to other 3 anti-diabetic medications, right? Dr. Beezer is quite familiar with other 3, but SGLT2 is the winner. Is here as #1 curve. If you look at here, survival curve, if there's a race to see how many people survive. And this is amazing because this is the first time you're seeing a series of real world data coming after real patients are receiving this medication in pharmacoepidemiology. Pharmacoepidemiology also shows relatively the same thing that clinical trials have shown. These are, again, veterans data on Dapagliflozin associated with greater preservation of kidney function. And also Dapagliflozin associated with greater reduction in body mass index. So one of the things that we can discuss is that these patients also start losing weight, and this is yet another mechanism probably that there is improvement in diabetes control. So this is one last slide before I summarize. One of my colleagues, Dr. Ian DeBeer from Seattle, and his colleague, they summarized here a number of things. For example, now, because this is the new era, we need now recommendations, what to do, patient selection, eGFR above 30, urinary albumin above 200, potential contraindications, genital infections, diabetic ketoacidosis. These are opinion-based right now. And hypoglycemia risk, yes, no. If high, then go over this algorithm and what to do. And different medications, Dapagliflozin 100 milligrams, 10 milligrams for DAPA and EMPA 10 milligrams, and the follow-up. So these are essentially, each center is now, the CKD clinics, the nephrology clinics are developing their own approach to use of SGLT2 inhibitors. And I'm going to summarize what I said. In summary, what we initially talked about was glomerular hyperfiltration in diabetic kidney disease. Is the initial phase of diabetic nephropathy. And usually when there is hyperfiltration, there is a very good chance that progressive kidney disease ensues. Increasing regular pressure can be overcome by SGLT2 inhibitors. I should actually, to be fair, I put ACE inhibitors and SGLT2 inhibitors because this is what 30 years ago ACE inhibitors and ARBs were supposed to do, and this is what now SGLT2 inhibitors are doing much more effectively. SGLT2 inhibitors exhibit consistent positive effects on the course of CKD independent of diabetes, as the etiology, as you have seen in DAPA-CKD, is now used in non-diabetic patients. And in fact, the package insert was just approved and expanded by the FDA to include indication for CKD patients independent of the etiology of CKD. Adverse events of SGLT2 inhibitors are rare, and the agent should be avoided if eGFR is below 25. For now, 25. I mean, if a patient's eGFR is below 25, we think about this, but above 25 indication, there is no contraindications. Potential additive effect with low protein or plant-dominant diets are still being discussed, and SGLT2 inhibitors should be considered as standard of care for conservative and preservative management of CKD. We are here to team up to have our patients live longer. As I said, living long with kidney disease is living well with kidney disease is the theme of 2021. Thank you very much.